non-invasive positive pressure ventilation, so BiPAP or CPAP or high flow nasal cannula, if those things are not working and you move and you have to intubate a patient. Just so you guys know, next week we're going to talk about some of the adjuncts for rapid sequence intubation, so difficult airway and other things you can do if. Oh, I'm going to have Dr. I'll just mute it. I can mute you. Anyways, so next week we'll talk about difficult airways and what we do if we're going to do something besides just RSI. So if you have questions or concerns about that, just know that maybe next week we'll talk about it. So getting started, what are the indications for intubation? Anytime we're doing a procedure, we need to know, why are we doing this procedure? The reason would be respiratory failure. That's really the primary reason why we intubate in the emergency department. Like we talked about last week, it's always good in these patients to try to avoid intubation if you can by using BiPAP or CPAP or high flow nasal cannula, doing all your other airway adjuncts, because it's not a benign procedure or treatment. For some people with respiratory disease, intubating them is not the best thing for them. Like asthmatics, if they get intubated, it can be really hard to extubate them. They can end up succumbing or dying. So just make sure that you do this with caution. And, if you need to intubate a patient to save their life, by all means do it, but just do it when it's appropriate. Other reasons to intubate would be an inability for somebody to protect their airway from aspiration. So if somebody is having a massive GI bleed and you're worried that they're going to aspirate, or if they are really altered, so if they're GCS, we typically say GCS under 8 is an indication for intubation because they can't protect their airway. If somebody has an anticipated clinical deterioration, so sometimes in severe shock, so septic or cardiogenic shock, you might intubate a patient, and that's because intubating them takes away that work of breathing and it allows the body to fight everything else that's going on. And sometimes that can help raise somebody's blood pressure if they're just tanking and they're on a lot of blood pressure medications, or if you think they have a lot of oral swelling or lip swelling, tongue swelling, that they might lose their airway, it might be good to intubate them before that's a major problem. If somebody has a burn in their mouth and you're worried that it's going to swell, those are all reasons to intubate. Another reason would be if you need to get diagnostic or therapeutic procedures done and the patient is just really combative, or if they're really harming your staff. I have intubated a really, really crazy person on drugs that it just was threatening the staff, and then we gave chemical sedation and they needed intubating. But if you need to get somebody over to get a head CT and there's just no way you can, then sometimes these patients need to be sedated to the point where they're intubated. Another thing that I intubate patients for, and I would, and I don't know if this is for any of you guys in your practice, if you're transporting patients, but if somebody is really sick and you think, okay, their airway's okay, but it may not be in 20, 30 minutes, then you might be appropriate to intubate them before you send them, especially if, they're going with a crew that isn't as skilled as you may be at intubation. So putting somebody in a helicopter or putting somebody in an ambulance for a 6-7 hour drive, sometimes it's easier to have that patient intubated, and it protects the patient, but also the crew. So before you intubate a patient, you want to assess what the intubation is going to be like. Airway assessment is really key, just to know what you're dealing with and know how hard is this procedure going to be. What might I run into? This is a procedure where you want to have everything ready, and assessing the airway will help you determine what adjuncts you may need. So you're going to look for what is going to make somebody a difficult airway, what components, and we'll talk about this again next week because it is really important when you're going to intubate. to know ahead of time if you're facing a likely difficult airway. So you want to look, not just is it going to be hard to intubate, but is it going to be hard for whatever reason to to um, intubate, or sorry, to ventilate the patient with a bag valve mask? Is an extraglottic device going to be hard? So an LMA or something you're putting back there. Is the actual endotracheal tube placement going to be hard? Or is it going to be hard to have a surgical airway? And there's kind of various things that make all of those different procedures in different parts of intubation difficult. There's a mnemonic that I think is pretty helpful. It's lemon. So it's just a one that helps you remember what components make up a difficult airway. So first you're going to look, is this somebody that has a short neck? Are they obese? Do they have a lot of fat around their neck? Do they have a huge beard? Do they have a big over or underbite? Do they have trauma or injury? Are there burns? Is there swelling? So just all those things that would jump out to you as making an airway difficult. And honestly, when you're doing an emergent airway, you need to do an airway really fast. Sometimes all you get to is the look externally. You're going to look, and after time and doing a lot of intubations and seeing airways, you'll have some better idea at assessing and deciding if somebody is going to be a difficult intubation. The E is for evaluate. There is these kind of 3-3-2 rules. And same with Mal-and-Potty. Those are both tools you can look and you can read them better than I can tell them. And I have the Mal-and-Potty on the next page too. And that's good if you have the time and your patient has the ability to show you what their mouth is going to be for you to kind of look inside, get a better view. The reality of it is that oftentimes the patients that we're intubating in the emergency department don't have the capability to really open their mouth for you to assess their Mal-and-Potty. You can't get them to move their neck or head for you to really be able to assess the distances that they want you to. And so some of these are, kind of intuition and what you see when you look on an external exam. The O is going to stand for obstruction or obesity, so any mouth swelling, but also obesity. And obesity can be a big detriment in a successful intubation. These people have a lot of fat around their necks sometimes, and that makes it difficult. It decreases mobility. It compresses the trachea. Some of that extra tissue will compress the trachea, limiting views. Sometimes abdominal fat can push up, kind of making the neck seem shorter than it's going to be. And so that can affect it as well. Also, the proportion of lung tissue to their body is smaller, so they're more likely to have desaturations really quickly when you're intubating. So you'll have to do these procedures quickly. So a lot of things can make it hard. And then the N is that neck mobility, like we talked about. And the biggest thing for neck mobility is going to be somebody in a C collar or with suspected cervical spine injury. You really can't move their head and neck a lot. And then also elderly people who have that kyphosis or the really, degenerative neck disease that makes it hard for them to extend back. So like I said, here's the Mal-and-Potty score. Typically, class 1 and 2 are going to be an easier intubation, whereas 3 and 4 are going to be more difficult. Sometimes the 3 and 4, they have large tongues or their anatomy is just like that. For these people, you need to be prepared first with surgical airways, with video laryngoscopy and other tools that we'll talk about next week. But, as far as Mal-and-Potty, it's something in our world we get tested on a lot, and it's good to know and assess if you can, but it can be really tough to have a patient, open their mouth so you can look if they're already in respiratory failure or they're altered. So you have to rely on the external exam. Before you intubate, I can't stress this enough, is the preparation for intubation. You want to make sure that you're well prepared for an intubation before you do it, and as much time as you can put into the preparation. I really recommend it. A lot of studies have showed that, especially if you're newer to the procedure, it's really valuable to have a checklist. In this lecture, I provided a sample checklist, or giving yourself one, making one for yourself. And so eventually you may not need it, but when you're learning and you're doing your first 100, you have that checklist to go through and make sure that you're checking everything off and doing everything beforehand, so that when you give the patients the medications to sedate them or paralyze them, you have everything you need. And being well prepared is what's gonna lead to success. So before you do the procedure and while you're getting your stuff ready, you can pre-oxygenate the patients. You can place a nasal cannula or a high flow nasal cannula on the patient, as much oxygen as you can. This is going to help flush the lungs of any nitrogen. That allows the oxygen to bind better, and it should give you a little extra time and decrease the likelihood of peri-procedure hypoxia. So if your patient has ARDS or an airspace disease like COPD or asthma, you can, and they're not altered to a huge extent, you can also use BiPAP or CPAP just for the pre-oxygenation. This gives them some PEEP, opens up the airways, allows better ventilation while you're preparing for the procedure. The nasal cannula, it's a good idea just to put on anybody, even if they have a BiPAP, before intubation, and then you can leave that on, especially somebody you think that might decompensate during intubation, or they're already hypoxic. No matter what you're doing, like some of our COVID patients, we couldn't get them over 80% no matter what we did. So that during intubation, there was risk that they would drop down into the oxygen saturations in the 40s and 50s. So making sure that you have the nasal cannula on that you can use even during the actual procedure. The next part of the preparation is just making sure that your patient is physiologically optimized. So intubation in and of itself is, it's a lot of stress on the patient. And then the medications we give, they can cause hypotension. And so if your patient is in shock or has another thing that is leading to low blood pressure, make sure you try to get that blood pressure up and do as much as you can before you have to intubate the patient, to prevent the patient from arresting during or right after intubation. So making sure that they get the fluids they need, that they are on pressors if they need to be, and having those things available to them. You can also use push dose epi. I included the how to make it at the end of this slide because I think it's valuable, but a push dose epinephrine is when you're going to mix an epinephrine with a small amount of normal saline. And if your patient is already hypotensive, it's good to just go ahead and have this ready for the intubation. And then you're going to make sure your room and your personnel are prepped and you have what you need. So make sure that you get all the people in the room that you can, that you want and you can spare. You don't want too many people because then there tends to be a lot of conversation and people aren't listening as much, but you want to make sure you have the hands you need. And then get your equipment. Make sure you're in a good position where you're comfortable, and don't be afraid to move the bed how you need to have the bed moved. And then you're going to go through your checklist. The equipment needed for standard intubation, you're going to need a bag valve mask with PEEP preferably, so that when you sedate the patient while you're waiting for medications to take effect, and you're getting yourself ready, you can bag the patient. A nasal cannula or non-breather for that pre-oxygenation. An oral airway is good to have. The little things you can put in the mouth just to open up. These are valuable during bag valve mask ventilation. If the patient has a beard or they have no dentition, that their teeth are missing, these are valuable. Nasal trumpet, so sticking something you could stick in the nose if you need to help with ventilation. Suction, if the patient has a GI bleed or is aspirating a lot, you may want 2 suctions, one on either side of the patient. You need your laryngoscope, so the actual device. There's 2 main ones, the Macintosh and the Miller. And it's really just preference. Unless it's a kid, I never use, I personally always use the Macintosh. The Miller is straight, and the actual technique of it is a little bit different. So the blade is straight versus the Macintosh blade that is curved. You need an endotracheal tube. I included there the sizes. So for an adult female, you're going to want to go 7 to 7.5, and for a male, 8, 8.5. As large of a tube as you can get in is beneficial. And for certain things, like if the patient might need a bronchoscopy or procedures done, really an 8 is the best for that. Maybe a 7.5 in a female, but an 8 is the best because they can stick the cameras down it. Also with asthmatics or people with any restrictive lung disease, a bigger tube is better because they get more oxygen in that way. You're going to need a CO2 detector or capnography that you can attach after intubation. And then it's always good, no matter if you think that's going to be an easy airway, you want to prepare in case it is not an easy airway. And so rescue devices, one would be a bougie, which you should have every time you intubate if you have that available. A fiber optic laryngoscope, which some of the new video ones just come with it automatically, but it's not available. I worked at a lot of places where they don't have that, or only anesthesia has it. And then a surgical airway kit. And the surgical airway kit's are pretty basic, just the bougie, which you already have, a scalpel, and then a smaller size tube. So here's that checklist I talked about. And, it's just, you go through, make sure you have everything. And if you can remember all this, or you're at the point where you've done a lot, that's okay. You don't necessarily need it, but it is really good. And it can be good to have in the room if you're doing intubations. So the nurses and other staff can also kind of check and make sure that you have everything, and they can help with some of this stuff. They can help gather it. If you have a good respiratory therapist, they're usually getting a lot of your stuff ready, or a nurse that helps. And so making sure they know what you need and everybody's on the same page, it's really helpful. So then jumping into the medications, it's really important when you're intubating a patient to medicate them, because it's an uncomfortable procedure, first of all. So nobody would want to be intubated without medications. It'd be tough, but also it's going to help your success. So if patients are well sedated and paralyzed, then all the studies show that they're going to have a higher first pass and success of actual intubation, like getting the tube in. If the patient's not well sedated or they're not paralyzed, then sometimes the vocal cords are still moving, they're still fighting you, and they can bite down, they can, it makes the procedure of the intubation much more difficult. There are times when you may not want to use a paralytic, but today we're talking about RSI, so I would. My go-to for most things is etomidate and rocuronium. Now, ketamine is also really good, and a lot of people just use that very consistently. But ketamine is good in a patient that is hypotensive. Sometimes ketamine is good in shock, because there is some data to indicate that etomidate may affect the adrenals, which can inhibit healing and make sepsis worse. So some people will use ketamine with septic shock intubations. In trauma patients, they weren't using ketamine all the time because there's some theoretical, kind of ideas that the ketamine could increase intracranial pressure, but that has kind of been proven to be wrong. And honestly, using the medication that's going to give you the most success and reduce the number of attempts is the best thing you can do to in trauma patients. So kind of whatever you're comfortable with, whatever you guys have available. Propofol is also a good option. It's just not great if the patient is already hypotensive, because you need propofol. When you bolus the propofol, it can lower blood pressure. But a lot of people will put the patient on propofol afterwards for sedation. So if you want to just bolus them, then you already have that medicine at the bedside, so it can be good. As far as the paralytics, succinylcholine, there's succinylcholine, rocuronium, and vecuronium. I almost never use vecuronium personally. Succinylcholine is a good option for patients with neurological problems because it doesn't last for very long. So if you need to do repeat neurological exams for any reason, you want to check if your patient is seizing, if you're intubating them for status epilepticus, things like that, succinylcholine is a great option. But for a lot of other things, rocuronium is nice because you're not risking any issues with the potassium. So crush injury, if you don't know what's going on, if they have metabolic abnormalities, rocuronium is a good choice. Do note that rocuronium, it takes longer. So if you're going to intubate the patient with rocuronium, make sure you wait a little extra time, about 60 seconds before you do the intubation. And it lasts quite a bit longer, which is why we don't use it as much in neurological stuff. It can last as long as an hour. So the technique of intubation is, something that you guys just have to practice in your labs, or if you have access to dummies, things like that, because it's really hard to lecture how to intubate a patient with technique. But once the patient is apneic, so not breathing, paralyzed, you're going to open their mouth and kind of scissor their mouth open. You're going to put the laryngoscope in and make sure you kind of stay above any pharyngeal secretions. You can use suction at that point, suck out if you can't see. And you're going to kind of keep identifying landmarks as you go through the mouth. If you're using the Macintosh, which is, I'd say, much more common, you're going to put the end of it in the vallecula, so kind of the little canal in the mouth, and then lift up. When you lift up, it should expose the vocal cords. There's very few situations when you should pass a tube without seeing the cords, especially as a less experienced intubator, because you're really likely to get in the esophagus. So once you see the cords, you can go ahead and insert the endotracheal tube. Typically want to go into at 20 on the side of the tube, says the length, so 21 centimeters for females, and 23 for adults, and that's usually at the teeth. And then if you're looking at X-ray, you wanted the tip of the tube to be 4 centimeters from the carina, which you should see on X-ray. So once you've intubated the patient, you feel as though the tube is in, you pulled the stylet out. You're typically going to attach a CO2 detector, so a little color change device, or just right onto capnography, and that'll tell you if you are in the right place. You're going to want to detect carbon dioxide. You usually want to wait 4, some people say as many as 8 breaths, but at least a few bagging before you say for sure that it's good, or wait a little time with the end tidal. Because if you're bagging the patient, then you're putting oxygen into the front of the mouth. So those first couple breaths, you could get a false detection of CO2 that even if you are in the esophagus, that was just sitting there from when you were bagging the patient. So make sure you wait a few breaths before you really say it's there. Then you're going to secure the tube, listen to breath sounds. You want a chest x-ray. If the patient is able, you can lift the head of the bed if they don't have spine injuries, and then set up the ventilator. The next most important thing would be sedation and pain medications. Having a tube in your mouth is not going to be pleasant for anybody. And you want to sedate them. They're also going to help. It's going to help make things easier for you, for the staff, and usually helps the underlying process. So if somebody is shock or they've already had really severe respiratory distress, by sedating the patient, you're going to typically lower their heart rate. That can increase their blood pressure, make them more comfortable, and help them heal, start to get better, and moving toward a better outcome for the patient. Some options for sedation are propofol. I put in here, you can see all the dosages and complications, but the most common ones are typically propofol. Then there's dexmedetomidine, and I can never say that because we always just call it Precedex. And so that's a great option. I don't know if that's a medication you guys have available, and it's really one used in the ICU frequently, and not all ERs stock it or are used to using it, but it is good. You can go up pretty low doses with Precedex, and patients tolerate it well, and there's low likelihood from delirium and other ICU complications with the Precedex. And then the next one that's used a lot is ketamine. Ketamine is nice because it gives you some sedation, but it will help with pain. Ketamine is great. It doesn't reduce blood pressure a whole lot. It's easy to titrate, so it's really easy. The titration is easy. And you can bolus it as well. So ketamine's a nice option. I'd say for me, most frequently, I'll either put the patient on propofol or ketamine. I don't really use the other ones a whole lot. If I use propofol, I will always give fentanyl pushes if needed for pain, because propofol does not address pain. So if you have somebody on propofol and you see their heart rate spike, or they bite the tube, or they look uncomfortable, then those would be reasons to give a push of fentanyl or some other pain medication. So setting up the ventilator, I mean, this is the whole, it's a deep dive into ventilation and vent settings, and beyond the scope of this lecture, and also a lot of times beyond the scope of ER doctors. If you're really struggling, it's good to contact a pulmonologist or get somebody involved. For me, mode, when somebody gets put on the ventilator, typically going to put them on an assist control ventilation, so volume control mode. What that basically is you set a rate for the patient, and if they are not breathing over the vent at that rate, they get a specific amount of oxygen. If they're breathing over the vent, so if they're breathing over the rate that you sent at each one of those breaths, then they'll get a little assistance. This is nice. Any patient can tolerate it if they're not breathing over the vent because they're altered, it's fine. But if they have like a metabolic acidosis from, say, DKA or some other process, this way they you're going to get all the breaths they need, and their body is going to allow that, and it doesn't fight them too much. And I think it's more comfortable for the patient. Tidal volumes, you're usually going to go with a volume, lung protective, just 6 to 8 milliliters per kilogram. And this is of predicted or ideal body weight, not the patient's actual body weight if they're obese. And then a PEEP, so positive end expiratory pressure, usually just start at 5 unless they have some other crazy thing. But without talking to pulmonologists or the ICU doctors, I'm not often going crazy on PEEP, but I do put everybody on 5 of PEEP. And then FiO2, you want to go as low as you can. So you can start at 100% and then titrate down so that their oxygen is between 88, 85%. Really 98 is fine. You just don't want them at 100% because then they can start to have lung damage, and you obviously don't want them to be hypoxic. So try to titrate, if you start them at 100 and then titrate them down as you can. The rate is really going to be based on what you're intubating them for. For a lot of disease processes, I try to, at least at first, I will see, try to measure what the respiratory rate is before you intubate them, and kind of start around there and then go down as you can. The only exception would be if somebody's in, respiratory failure from COPD and they're just breathing so fast, and you want to try to go a little lower on the rate. Decreasing the rate increases the amount of time the patient has to exhale. So in asthma and COPD, you get air trapping. So lowering the respiratory rate increases the amount of time the patient has for expiration and getting rid of that air, so they don't start trapping air, getting air, and causing lung damage or pneumothorax or other complications. After about 30 minutes of the patient being on the ventilator, you can get a blood gas and see what they're doing. So look at their pH, their oxygen, and their CO2, and see if you need to make any adjustments. So that is kind of the conclusion of the lecture part, and I have some questions, but I want to see if anybody has any questions, concerns, comments. You can write it in the chat too. I know it's a lot too, and I'm sure it's hard in your second language, but I will make sure at the end of this block you guys have these PowerPoints too, and I try to include some things on there. Huh. I'm not seeing, I see somebody did a chat and I can't, let me just, yeah.
Just agree because in the pediatric they get big heads than the others, and they get small residual lung capacity than the others. Yeah, and the tongue usually in the children is more larger than the others, and the the smallest part of the children airways in the bronchopathology, not like in the others. In others, usually the smallest airway in the vocals. Some different in
Yeah.
the yeah.
Yes, definitely. So this question, yeah, how does the pediatric airway differ from the adult airway? And A, right mainstem intubation is less common in adults. B, the head is relatively smaller in children than adults. C, the residual lung capacity is larger in children than adults. Or D, the tongue is relatively larger in children than adults. And yep, she's saying D, the tongue is relatively larger um, in adult than in adults. And I don't know if anybody had any other thoughts, but that was right. So the pediatric airway, the tongue is going to be larger. There's some other differences. The larynx is going to be smaller. The narrowest portion is the cricoid cartilage. The epiglottis is longer and narrower. So your epiglottis is going to be big and floppy in kids. The head and occiput are proportionally larger. The tongue is larger, like we talked about. Neck is shorter. Larynx is more anterior and cephalad, and the adenoids are larger. You have a high risk of right mainstem intubation because everything is so short. People tend to just kind of go through. I don't think you guys do a ton of pediatric stuff or see kids as much or have hope or not doing pediatric airways, but it's good to know in case you do run into it. We're talking about the Macintosh versus the Miller. In younger kids, some people will use the Miller, the long straight bladed laryngoscope, because what they'll do is they'll insert the Miller all the way and then use it to lift up the epiglottis to view the vocal cords. So for some people, for pediatric airways, they like to use that one because that epiglottis is so large and kind of flops down. Uh, one more pediatric question. Which of the following patients undergoing emergent intubation would most likely benefit from pre-treatment with atropine? So atropine, remember, is going to increase the heart rate. An 11-year-old being given etomidate and succinylcholine for severe injury. A 3-year-old being given etomidate and rocuronium for seizure. 4-month-old being given etomidate and succ for bronchiolitis, or an 8-year-old being given ketamine and rocuronium for asthma. And you guys can write in the chat. I had to exit the thing because I can't see the chat. If I'll put it back so you can see. Does anybody want to give it a shot? I just want to see the answer that you guys given all. So yeah, this one's tough, and I'm sure it's really tough because you guys, if you don't see kids, but I kind of put this in so we could talk about pre-treatment with medications. But for this one, it's C, actually, a 4-month-old being given etomidate and succinylcholine for bronchiolitis. So pretty much any kid under 1 year, you would pre-treat with atropine because they're so likely to get bradycardic from messing with their airway. So if you're going to intubate a really young infant, then we would give atropine. I understand you guys probably don't do a lot of pediatric intubations or see a ton of pediatric patients. This is a good spot to talk though about pre-treatment. They used to recommend pre-treatment with lidocaine more often. Some people will still use lidocaine if there's severe trauma, head trauma, or there's bleeding in the brain from hemorrhage or a major stroke, because it can maybe decrease that rise in intracranial pressure. And then also reduce airway secretions. So, I've used it a couple times when I've had patients with head bleeds that are really decompensating or they have a midline shift. Then I've used lidocaine to pre-treat these patients. But I don't use it otherwise routinely. And that would be for pre-treatment. You could give that just before you give your RSI meds. So just, probably 5 minutes before you give the rest of your RSI meds is when you would give that lidocaine. Atropine, I haven't used that for pre-treatment except for in kids. You could use it if your patient was, say, had a complete heart block and was in cardiogenic shock from that, and you felt they needed intubating. It might be a good idea to pre-treat with atropine. But with atropine, you can also just be cautious with your medications. Instead of pre-treating, be cautious with your intubation meds. So maybe giving ketamine that will increase the heart rate a little bit naturally. But it's good to know that you can think about giving other meds as pre-treatment. So adults now, which of the following is true regarding rocuronium for rapid sequence intubation? A, dosage is 2 milligrams per kilogram. B, duration of action is 10 to 15 minutes. C, it is depolarizing neuromuscular blocking agent. Or D, the time of onset is 60 seconds. Any other guesses? Sorry, I just want to look at the chat. So, yep, this one's going to be D. Time of onset is 60 seconds. So we talked about this. So rocuronium is going to take longer to take its effect. So it's going to take about 60 seconds. So remember that, push your sedative, and then some people will actually push like the rocuronium first and then the sedative, especially with the etomidate, because the etomidate, it's really quick to come on and then it takes a little longer to come off. So just sequence of when you give your medications. I still like to give the sedative first because I would hate to, paralyze the patient without having them sedated. But you have a little bit longer, so make sure you have the patient bagging and you have a good mask and good seal while you're waiting for that, because they all will be sedated, so probably not breathing a lot on their own. The rocuronium is going to be the only other thing with the dosing for rocuronium is going to be 1 milligram per kilogram. And I also like that dosing because it's easy to remember, 1 milligram per kilogram. So that's nice. So next question. Which of the following would help reduce high peak pressures in patients intubated for asthma? We got So we've got a couple answers on this one. This is a hard question for sure. So this one, the answer is actually going to be D, using a larger endotracheal tube. So using a larger tube will reduce the resistance in the airway, and actually then reduce peak pressure. So how much pressure there is, because there's less dead space and less resistance. So remember from college or high school that resistance of flow is inversely proportional to diameter. So resistance is inversely proportional to diameter. So increasing the tube and the size of the tube will decrease that resistance that's met. It can also allow for easier suctioning, so you can suction out secretions. A lot of secretions in asthma will increase your peak pressures as well. So if you can suction, make sure there's no secretions in there. That'll help. So, and lastly, with it won't meet resistance on the exhalation if the tube is bigger. Kind of like this is saying, so they can exhale more air. They're not building up air. They're not getting those peak pressures that are high. And you measure peak pressure with the ventilator, and we'll talk about that a little bit on like the 4th lecture. So not next week, but the week after, and complications of intubation and the ventilation, things like that. But just this is kind of to harp on the point that the bigger the tube you can get in and pass, the better it is, for the patient for a lot of disease processes. And last question. A 76-year-old man presents to the emergency department in respiratory distress. He continues to be hypoxic despite bi-level positive pressure, airway pressure. As he becomes more altered, he no longer tolerates BiPAP, so the decision is made to intubate. His blood pressure, despite adequate IV fluids, is 80/52. You estimate his weight at 70 kilograms. Which of the following strategies is most likely to decrease the risk of peri-intubation cardiac arrest? A, induction with 20 milligrams of etomidate and availability of push-dose epinephrine. B, induction with 20 milligrams etomidate and availability of push-dose epinephrine. And you can see, so this one for the push-dose epinephrine is saying the first one, 1 to 1,000. I just want to make that clear. And the second one would be 1 to 10,000 epinephrine. C, induction with 200 milligrams of ketamine and availability of push dose epinephrine, 1 to 1,000. Or D, induction with 20 milligrams ketamine and availability of push dose epinephrine, 1 ml to 1 to 10,000.
In this question, I choose D because I don't want to compress the patient respiratory rate because the patient gets a worse respiratory distress if we get another sedation. So it can be affect the patient respiratory rate and they can get more worse the hypoosmia. And ketamine we don't want lower hypotension. So we can use this ketamine and we be careful use with epinephrine to prevent the peri-intubation cardiac arrest.
Yep, you're completely right. That was a really good explanation and you're right on. So when we're intubating hypotensive patients, you might want to use a smaller dose of medication. Like in this case, you would, like you said exactly, ketamine, it's good. It's not going to cause the hypotension as much. So it's a good choice. And you could use that lower dose. You don't have to, you wouldn't go to 200 milligrams. You might do more like 1 milligram per kilogram, or in this case, even lower than that. To prevent that. And the etomidate, you can't really use lower doses in etomidate, and you're more likely to cause hypotension. And then, yep, the push dose epinephrine this is the exact patient that you would think about a push dose epinephrine in. He's hypotensive before and he's already gotten fluid. So, you could give him a dose, see what he does, even another dose to see if he needs it. And then you have that to give if he becomes even more hypotensive. The push dose epinephrine, so I put it here. So you're going to use the 1 to 10,000 dose of epinephrine. So that's the epinephrine that you use for cardiac arrest. That's usually the epinephrine that's in a crash cart if you have it, not the epinephrine you would give for asthma, for an allergic reaction. This is your code epinephrine, 1 in 10,000. So you can take that vial, you insert it into the saline. So you squirt out 1 ml of saline and insert 1 ml of epinephrine. And then you end up with 10 mLs of this push dose epinephrine. When you have it, you could give here it says 0.5. I would never just give 0.5 of the push dose epinephrine. It's hard to measure that amount when you're giving it in a syringe. You lose a lot in the tubing. So I would do 1 to 2 mLs every 2 to 5 minutes. And then wait about a minute and make sure that it circulates before you see what you're doing. You can give this just fine through peripheral IV. If you are getting down to all of the 10 mLs or you find yourself doing this, then that means that your patient probably needs to be put on a pressor. So don't just use this in lieu of putting them on norepinephrine or an epinephrine drip. If they need it, this is to be used if you think that their blood pressure will come up after a procedure, or you just need a little something extra. So yeah, that is kind of concludes this week's lecture and the questions, but I'd love to hear if anybody has specific questions for me, or you can write them in the chat, anything. I went here. Does anybody have any questions? I'd like to know what medication are you guys using if you're intubating patients? What do you typically use? Or does it vary? You can write it in the chat. No, I got no takers. Well, I'll tell you, I like I said, I use ketamine usually. I for a lot of things, and I etomidate, and I like etomidate for, you know, patients in respiratory failure from COPD or asthma. I usually or COPD. I usually like etomidate because it's so fast and reliable, and nurses are really familiar with it here in the States. I'm starting to use ketamine more, and I think